since talk to us about fracture around the shoulder in children.
Hi, Tarun. Can you hear me okay?
Yes.
Yes, sir.
Yeah, we can hear you absolutely fine. Loud and clear. Yeah.
All
So,
right.
Sheetal, this fracture around shoulder in children has something which it's not been discussed so much in different platforms. So we are also very keen to learn and know about it. And I'm sure a lot of concepts have changed in the recent year, and we will get to know. Sheetal, yeah. We can start.
Okay. Can you see my
All
screen?
clear, no? Yes, very well, very well. Yeah, excellent.
Okay. So in the next hour, we'll just talk about some fractures around the shoulder and our experience with treating these injuries. Now, a lot of these injuries, when it comes to joint involvement, like the SC joint, AC joint, or the glenohumeral joint, it falls within sports medicine. So that's why, peds or as a pediatric orthopedic surgeon, you may not see too many of, joint dislocations, but you should be aware of at least the principles of treatment. And I'll discuss, since I do sports medicine, I take care of all these injuries anyways. So I'll discuss a few things about these injuries as well. I would like to credit Stephen Frick. Some of the slides are borrowed from the Orthopedic Trauma Association resident curriculum. And there is a course for the residents on OTA. So if you're a member, you can access a lot of these presentations. And I'll also like to credit my colleague, Chuck, and I borrowed a few slides from him. And he has done quite a bit of research, at least on the clavicle fracture part of it. So we'll start with some anatomy where you need to know what the normal ossification centers and physis are around the shoulder. One of the reasons is that you may be called for a fracture when it's actually not a fracture, it's just a normal physis, and that happens often when someone has an injury and you're called to evaluate, and the CT or the MRI shows that there is, for example, a coracoid base fracture. If you know that the coracoid base does have a physis, then you would understand that it's not a fracture. Whenever in doubt, you can always get a contralateral X-ray. Similarly, there are ossification centers for the acromion, the glenoid, and one should be aware of those centers to avoid missing true fractures. We'll talk a little bit in depth about clavicle fractures. These are most common fractures in children. Fortunately, most of them are in less than 10 years of age in the midshaft, where healing is not an issue and malunion is not significant. It remodels very well, and complications are uncommon. So these are for kids who are less than 10 years of age. Most of them are midshaft, and then you'll have a few fractures involving the distal part of the clavicle, and uncommon, but it can involve the medial part of the fracture, medial part of the clavicle as well. And you need to be beware of the nutrient foramen, not to miss it, not to think of it as a fracture. Green stick fractures are common. They heal very well, but as with other green stick fractures of long bone, the callus is a little bit less compared to a complete fracture. So there is a higher refracture rate when you see a green stick fracture, and it's better to make the family aware of it. Typical healing, even if the fracture is completely displaced, you have the periosteal tube intact, and that would lead to ossification between the ends and healing of the fracture. When the fracture is at birth, it's typically in a large baby. There is pseudo-paralysis. That is where it's challenging to differentiate the pseudo-paralysis because of a clavicle fracture versus true paralysis from a brachial plexus injury. So there are ways to evaluate for that. You can do some reflex, the Moro's reflex, as well as wait a little bit. If it's a true clavicle fracture, it should heal in 3 weeks, and that would give you a better assessment of the brachial plexus after that. We all know about absence of clavicles, which is cleidocranial dysplasia. We have seen patients like this, and they typically do not need any treatment, but just to be aware of the pathology. Whenever the clavicle is fractured, there could be more than 2 fragments. If there is combination, it does become a little bit difficult to treat it surgically. So you need to be aware of the fragment, which is vertical, which is also known as the kickstand fragment. We all think that it's a kid, they all do great and they all do fine. But if we look at the growth rate of clavicle, up to a certain age, the growth in males and females is the same. But after 12 years of age, the growth rates are different. What that means is that when we are evaluating clavicle, you need to look at whether it's a boy or a girl. In a girl, typically by the age of 9 years, 80% of the growth is done, which means that if there is shortening, if there is a significant bump, if there is any malunion, it's less likely to remodel in females beyond that age. Similarly, in males, it's usually around the age of 12 years when 80% of the clavicle growth is complete. So same thing is that the malunion may not remodel after this age. And so the bumps may not be small, they can be a cosmetic issue. You need to make the family aware of it in older kids that could be a permanent bump when the fractures heal, and they would not remodel, they would not go away. Now, the fragment that is a comminuted fragment can frequently poke into through the subcutaneous tissue, and this is called true tenting of the skin when there is the end of the clavicle is just underneath the skin, and it can become an open fracture anytime. When we talk about the indications of surgical treatment of clavicle fracture, one of them is tenting of the skin. But I've seen residents calling any displaced clavicle fracture as tenting of the skin. So you need to differentiate that just a bulge around the mid shaft is not tenting. A tenting is that it can become open at any point, just like this fracture here. And if we look at the non-union rates in children, there are previous series that have reported, such as this one, that when they treated 14 patients with non-union, there were 3 patients who were pediatric patients or less than 16 years of age. Similarly, in this series of clavicle non-union, there were 2 patients less than 16 years of age. And a third series here had a couple of patients who were less than 18. So non-union does happen, especially in the older adolescent age group. You need to make the family aware of it. That is not an indication to offer surgery to all patients, but if there is a non-union, then of course they would need something, especially if it's symptomatic non-union. They would need surgical treatment. So you need to make the family aware of the possibility of non-union. Here is a 15-year-old male treated at our institution at 4 months follow-up. There was a painful non-union, and the patient underwent surgical treatment. So it does happen. It happens in younger patients as well. Here is a case report of a 10-year-old boy who had a closed shaft fracture that did not heal and went on to require surgical treatment. We can go a little bit younger. This is an 8-year-old girl case report who had a non-union of the clavicle and underwent surgical treatment. And this is the case report of the 8-year-old girl. You can see a frank non-union and then healing after the fracture was stabilized at 10 months. Here's a 4-year-old male. This was a patient of one of our fellows who was in practice in New Orleans. He had sent us this patient, 4-year-old. This is 1 month after injury. This is 2 months after injury, 4 months after injury, 5 months after injury, 6 months after injury, 8 months. and then underwent surgical treatment, and this is 6 months follow-up. So you could see even in a 4-year-old, it's possible that they can have a non-union. It could be interposition of tissues, it could be nutritional deficiencies, and you don't want to miss a congenital pseudoarthrosis, which is not painful most of the time. It's asymptomatic. So what is a symptomatic malunion then? So malunion does cause some glenoid malposition. In this cadaver model, there was some functional abduction deficits when you had significant shortening. Here is another study about the shortening effect on the scapular kinematics. The 12 cadaveric shoulders and shortening was from 0 to 20%. And as you can see that once you approach 10% of shortening, which typically is around 2 centimeters of shortening, then there is decreased external rotation of the scapula. Here is a clinical series from JPO. 17 patients were treated surgically, 25 were treated non-surgically. And of the 25 patients, 20% had complaint of pain. So malunion can also lead to pain besides the functional deficits. And 4 out of these 5 patients required an osteotomy and fixation at more than a year after injury. So malunion is not benign, especially when it comes to older adolescents. And they can present with scapular winging. Here's a patient from McKee, and they reported symptomatic scapular winging in patients having malunion of the clavicle. And there is a role of doing an osteotomy of the clavicle to resolve the scapular winging. Here is a functional and radiographic outcomes of non-operative treatment in adolescent patients. They strength tested 16 kids with malunion, and there was about 10% decrease in the strength in external rotation and abduction. It may not translate to clinically meaningful weakness, but there are deficits. Some patients may have more than 10%. Another series about 16 clavicle malunion patients, they had reduced flexion and abduction motion, though the strength was not an issue, and one patient needed corrective surgery. Here is the example of the patient with a malunion that required corrective surgery because of restricted movement. The other issue is that the pain could be from an entrapment of the supraclavicular nerve. This is a patient who had significant pain because of the entrapment of the nerve in the fracture callus. And similar reports have been in the literature about this 26-year-old male who had surgery at 7 months because the patient had significant pain from entrapment of the nerve in the callus. So the nerve can also be affected after surgery, so you want to be careful when you're doing dissection, especially if they're big nerves. I don't think you need to spend a lot of time, but you need to be careful and vigilant about the nerve when you're doing operative fixation, especially in females, because if you look at the distribution of the nerve, it extends into their anterior breast area, and that can lead to some significant numbness in that area. You can see that some cutaneous distribution can extend far into the chest wall, and so it can lead to some numbness, which could be an issue especially for females. So you need to be careful about this nerves, especially if they're robust. This is one of my patients. You can see that on the top that we have preserved the nerves here during operative fixation, and still the patient had the numbness, post-op, just in the inferior aspect of the clavicle. So it's there. If you check it, you would notice it. Patients may not complain of it, but if you ask them, then there is going to be some numbness if you stretched or violated the nerves. The outcomes of displaced pediatric fractures, here is a series 32 non-operative treatment versus 46 surgically treated patients. And the main thing is the bottom 2 lines. What are the issues with surgical treatment? That some of them may need the plate to be removed. And there were 3 fractures adjacent to the plate. And we have seen fractures, peri-implant fractures, where second surgery is required to fix the stress fracture at the end of the plate, especially in younger patients. The issues with non-surgical treatment is refractures and 2 patients took a long time to heal, more than 7 months to heal. So return to sports, if it's important, then that might be an issue if the patient has significant more time for healing. In this series comparing surgical and non-surgical treatment, again, non-surgical treatment, they were back to sports at 4 months, and surgical treatment back to sports at 3 months. About 1 month difference how fast they can return based on surgery versus no surgery. But if sports is not a major factor in your decision making, then it doesn't make sense. 1 month is not that long of a period. Here is a 13-year-old patient who went to sports too soon. He was treated with surgery, and this is refractured at 4 weeks. He returned to sports. So return to sports sometimes is pretty big when the family, the coach, and everyone is pushing them to get back. But we also need to make sure that the minimum time, I would say, is around 3 months when they can return back to heavy work. Need to be careful about congenital pseudoarthrosis of the clavicle, usually on the right side, except patients with dextrocardia. Now, in younger patients, we don't treat these because they are non-symptomatic, but in older patients, they may complain of cosmetic deformity, sometimes functional issues, sometimes some weakness and pain. There are a lot of reports about treating pseudoarthrosis with excision, tricortical graft, and fixation. So here is one of my patients. When I saw her, she was around 14, 15 years of age. This was a while back, and she was symptomatic. I tried to treat her with physical therapy rehab. She was symptomatic, and so I took the plunge. I treated her. The one thing that you don't recognize is that the ends of the clavicle don't have vascularity till you excise significant part of it. So if we measure the contralateral side and we think that, okay, we need a 2 centimeter graft, intercalary graft or tricortical graft, per intra-op, it may be more because you have to excise till you get bleeding bone. So here is the intra-op image of this patient. So there was excision of the pseudoarthrosis and reaming of the canal till we see some bleeding, and then an iliac crest tricortical bone graft that was then compressed between the 2 fragments. The patient showed up at about 6 weeks and 10 weeks, and it was showing signs of healing, and the patient was happy and didn't show up for 2 years. And then she came back after 2 years, and this is the X-ray. And what it shows, it's not just a non-union here, but there was infection as well. And I had to remove everything, excise it. I did not refix it. But this just tells you that if possible, avoid surgery for pseudoarthrosis. There are more risk, more complications, even though you do everything that has been described, even though you try your best. You can see the graft or the tricortical part of it is completely absorbed here. There is no graft between the 2 ends, and everything is loose. Let's just talk a little bit about distal clavicle fractures or an AC injury. Often the periosteum is intact, and hence the clavicle remodels very well. It may look really bad on the x-rays, but most of these patients can be treated non-operatively, and they would remodel very well. There is a classification system which is similar to a dose. I won't go in details since you might not see too many of these. AC joint classification, if you just want to remember, 1, 2, 3 are treated conservative, 4, 5, 6 are treated operatively. What you have to differentiate is a type 3 from a type 5. And sometimes you need to be concerned about the diagnosis itself. And I'll come to that point. These are the periosteal sleeve injuries that have been described. So you can see the normal is on the top. And what happens when you have a distal clavicle fracture, the coracoclavicular ligaments, which are here, they remain intact, keeping the sleeve intact. And over a period of time, this fills in with bone. And so you almost have a double clavicle or a Y-shaped clavicle. And then the top part would get absorbed. So you can have remodeling in younger patients, as seen here in F. But for some time, you would see this picture in D, which almost looks like there are 2 clavicles. then the periosteal sleeve would fill in and it would remodel. So a lot of times we get called about this kind of an X-ray, that the patient has AC separation. And the radiologist would call it an AC separation because they don't have a clinical picture or the X-ray of the other side to compare with. What we have to remember is that in younger patients, this is a normal X-ray because the entire acromion and distal clavicle is not ossified. So it gives you an impression that there is an AC separation. The two things you can do to convince yourself that this is not true AC separation. One is to clinically look at the patient. If you look at this patient, yeah, it is prominent. AC joint is prominent, but how about the other side? Look at the clavicle on the other side. It's a bilateral normal AC joint for him. If you look at the other side, you can see the same X-ray. So this is not an AC separation, but it is a normal AC joint for this patient. A true AC joint injury would have asymmetry. You would have some bruising, swelling, pain around the site of injury, and you would have difference, as you can see here on the X-ray. So my recommendation would be always take bilateral clavicle X-rays or a chest X-ray to evaluate for AC joint so you can have a comparison with the other side. This is an example of a type 4 dislocation, which is mainly a posterior displacement of the clavicle into the trapezius. And you can see here how it looks from the front when the clavicle is pushed back, and then from behind when the clavicle is, this is the end of the clavicle. It's supposed to be aligning here with the acromion. Instead, it's been pushed back. And that is an indication to get it out of the trapezius and fix it. There are different ways of fixing the AC joint. Typically, it's a combination of suture and a biologic. Sorry, Taral? Can you hear me?
So, Shitul, sorry, that was a mistake. Yeah, I can.
Yes, you're audible, sir.
Okay, should I continue?
Yeah,
Please go ahead. Go ahead.
So I pressed some different button by mistake.
Okay. So the ways to fix the AC joint at this time, previously it was a Weaver Dunn method of fixation, where you would take the part of the ligament, the coracoacromial ligament, and put it in the distal clavicle to hold it. That is not being used anymore. The Weaver Dunn method is an older method. The newer, better way of fixation is the coracoclavicular ligament reconstruction, which means that you make a hole in the clavicle just above the coracoid. You put a suture around it and also use biologic material. It could be an autograft or an allograft, but you use soft tissue tendon graft to loop around the coracoid and reconstruct the CC ligament, and that gives better results with AC joint separation. And I'll just talk a little bit about the medial clavicular injuries. The medial clavicular physis is the last to close at the age of 22 to 24 years. Most of the time, the displacement of the clavicle is anterior and it's not that big of an issue. You can ignore it. There are going to be some cosmetic concerns, a little bit of pain and weakness initially, but with therapy, they would do well. The concern is when there is displacement posteriorly, especially if it's going to compress on any of the important structures. This injuries might be missed. It has been missed at our institution as well, especially when the patient has multiple trauma or multiple injuries. So the best thing is to do a secondary evaluation on these patients. The X-rays do not show it because there is going to be an overlap of the ribs, the sternum, the vertebrae, as well as the lungs. So you may not get a clear view of the SC joint. So either you can do the serendipity view, which is an oblique view of the clavicle, or you can get a CT scan. So this is a CT scan which shows the posterior displacement of the medial clavicle. As far as the treatment is concerned, if it's a physeal injury, you can reduce the fracture and you can suture the medial clavicle to the physis. If it's an acute sternoclavicular joint dislocation posteriorly, you can do the same thing. You can reduce it. You can suture it to the articular disc, which is pretty robust. And if it's a chronic posterior sternoclavicular joint dislocation, then you need a ligament reconstruction, making 2 holes in the medial clavicle and 2 holes in the sternum. Doing medial clavicle surgeries, there are protocols. That means that it's better to have a vascular or a cardiovascular surgeon involved, especially in chronic cases when there may be adhesions between the clavicle and the arteries underneath. It depends, at our institution, we usually have a cardiac surgeon just informed. We don't have any arrangements to open the chest if needed, but it differs from an institution. I was speaking with one of my colleagues at CHOP, and they have, everything prepared to open up the chest right in the OR. So this surgery, you should not just do it in a smaller setting. This is better to be done in a hospital or a bigger setting, since there is potential for iatrogenic injuries. As far as scapular fractures are concerned, there may be a sign of significant trauma. Usually non-operative treatment is sufficient. Again, if you want to evaluate it better, CT scan is helpful. There are growth centers which may be confused with a fracture, and they can have fracture through common growth center, just like seen here, coracoid and glenoid. There is a whole classification system involving the body, the neck, the glenoid, the acromion, coracoid, and intra-articular or extra-articular. The ones that I've treated surgically or ones that are important are some form of coracoid fractures, which can lead to some stiffness and weakness over a period of time. Glenoid fractures, if they're intra-articular involving significant part of the joint, that might need to be fixation, but most of the body fractures are treated non-operatively, and same with the acromion fracture. Unless it's a symptomatic non-union, then you can go ahead and fix the fracture. As far as dislocations, it is rare in children less than 12 years of age, but these patients have a lot of joint laxity to start with. In younger patients, I'm not too much concerned about recurrence. I'm more concerned about patients after the age of 13 or 14 years, because then if they have a dislocation, they would have significant recurrence. So my algorithm for treatment for glenohumeral dislocation is, of course, you reduce them, and then you evaluate it. We use MR arthrogram to evaluate these patients. If they have any bone fragments or bone loss, we'll get a 3D CT scan to evaluate for bone loss. That does factor into the treatment. If the patient is on the younger side, I would treat them conservative, typically less than 12 or 13 years of age. I would treat them conservative, but if they are beyond that age, that means they're approaching maturity, my recommendation would be to fix it arthroscopically. So do the Bankart repair or a labral repair, depending on where the tear is. But these are surgical treatment for older patients, older adolescent patients. Glenoid dysplasia may predispose to instability, though we need to recognize it. We are not doing any treatment except when it comes to brachial plexus palsy. You can do some treatment in glenoid osteotomies, but this is not a trauma case. As far as dislocation, we mentioned about rehabilitation and immobilization, especially in younger patients, but surgical stabilization would be my preferred treatment after about 13 to 14 years of age. You can get atraumatic instability, which is usually common in younger patients because of generalized joint hypermobility. We have a lot of diagnoses of Ehlers-Danlos syndrome here, and we have a referral center for that. So we see a lot of patients, younger patients with multidirectional instability. They are treated conservative till they are 13 or 14 years of age. If after that, and if they have once failed conservative treatment, then surgical stabilization is recommended for MDI patients. Let's come to the next bigger topic, which is the proximal humerus fractures. These can be both injuries when they are younger. It's usually a Salter 1 fracture. When they're a little bit older, they're metaphyseal fracture, and then you will get some Salter 2 fractures between 11 and maturity. The intra-articular injuries, which are type 3 and 4, are very rare in our pediatric population. If you just look at the ossification pattern of the proximal humerus at 3 weeks, you don't see anything. Here is at 8 months, you see the primary ossification center of the proximal humerus. If you're lucky, you would see the 2 centers, which are, the tuberosity ossification center and the head ossification center like this, but it's a smaller window. And then they would fuse together. At 7 years, you would see the Physis as one. As far as the radiographic interpretation, you should know the shape of the Physis. You can see how in external rotation, you will see a tent-shaped Physis. In neutral rotation, you would see this pattern, and again, a tent-shaped in internal rotation. So the Physis has like 2 peaks in external rotation and internal rotation. You would see those peaks. And on a neutral rotation, you can see this is one peak and this is another peak here. So there are 2 peaks, and you would see both of them based on how you rotate the joint. Axillary view, again, you want to make sure that you can evaluate the acromion very well. You can see some mesoacromion or the non-ossified part of the acromion when it's developing in here. You can see that the joint is well centered. If you want to look for any misdislocation or subluxation, you can see the coracoid very well here. And if you have a base fracture, you would see right in this area the coracoid base fracture. And you can see your greater and lesser tuberosity fragments very well. So an axillary view is extremely important. It's part of our routine series of x-rays for shoulder, the axillary view, the scapular view, and the AP view. Neurovascular, the most important structure that when you come near the coracoid here is the musculocutaneous nerve. So if you are doing any coracoid work around here, you need to be aware of the musculocutaneous nerve around here. When you're dealing with proximal humerus fractures, you're more concerned about the axillary nerve, especially when you're pinning, and I'll just point out a few things how to avoid an axillary nerve injury, but these are the important structures that you need to be aware of: the musculocutaneous nerve and the axillary nerve. Very rarely you can get this kind of intrathoracic displacement of the fragment. You have to be really careful because this may be resting on all your neurovascular structures here, and it might be better to have a general surgeon involved when you're dealing with such intrathoracic injuries. This is from one of the case reports. You can see there is tenting of the axillary artery on this fragment here. There is biceps tendon here, and the flap of the flap that was from the metaphysis is up here. You can see the type of injury once the reduction is done, but you have to be careful because there might be axillary artery injury with this kind of displacement. We already looked at the age-related injuries, but again, from birth to 5 years, it's usually SALTER 1. 5 to 11 is metaphyseal fractures, which are typically treated conservative. And then 11 to maturity are SALTER 2 fractures, and we'll come to the treatment of that. There is a near Horowitz classification. It's based on the amount of displacements. If you have grade 1 less than 5 millimeters, then based on the width of the shaft. The typically grade 1 and 2 are treated conservative. When it comes to grade 3, that means significant displacement of the fracture, especially after the age of 11 years. Then you start thinking about reducing these fractures and fixing these. However, the classification does not account for angulation. So you may have significant angulation. So say, this is a 90-degree angulation, but if as per Neer and Horowitz grade, this might be a grade 2 or 3. So it doesn't truly give you a sense of how much of the displacement there is, because it's just based on translation rather than angulation. Also, the combined deformities are always more than what you see on the AP and the lateral view as seen on the CT scan. So close treatment for vast majority of these fractures, 80% of the growth of the humerus is from the proximal physis, so there is excellent remodeling potential. And you also have compensatory shoulder range of motion. So if you have some malunion, it's not a big issue. If markedly displaced, that is type 3 and type 4, then we should attempt close reduction and immobilize. And then if the reduction is unstable, then you need to fix it. And there are different ways of treating this. Most of them are percutaneous ways of pinning and screw fixation. As cutoff age is 11 years, after which you should give consideration to surgical fixation because of limited remodeling. This is an example of remodeling of the fracture. It remodels very well in most of the patients. And you can see some injury x-rays, and after it was reduced, you can see the healing. You can do it in a beach chair position. You want to make sure when you're reducing and pinning these fractures that you can get orthogonal views. This is one way of doing it, is in a beach chair position. The other way is a supine position, where you can rotate the C-arm and do an AP and a lateral view. The reduction maneuver that you typically need for proximal humerus fractures is abduction external rotation with some traction, and then you push down on the distal part of the fragment, and that is what gives you the reduction. So abduction, external rotation, and then pushing the distal fragment posteriorly, as seen in this inset here. You give a push here, and that is what reduces the fracture. So once you reduce the fracture, and if you rotate the arm back, it's going to lose the reduction. So the recommendation is, if you're going to pin this fracture, you pin it in this position. You put one pin right from here into the humerus. The problem with pinning it in this position is that when you get the arm in a neutral or a functional position, there is going to be significant tenting of the skin, because you have pinned it in one position, but the final resting position of the arm is not going to be abduction external rotation, but it's going to be with the arm by the side and internally rotated. So that would lead to significant tenting of the skin. So the way to prevent that is that you put a temporary reduction pin here. You put the arm in a functional position and then do your routine pinning and remove this pin afterwards, so you don't have that much tenting. So this is the force that you need, is a directed, posteriorly directed force. And as far as trying to avoid the axillary nerve is usually about 5 centimeters from the acromion. So I always make a mark here, so I know that I need to start distally, and that is where I would avoid. So I don't want to start in this area where the nerve is with my pin, but I would rather start distally. I can come from the top and go down like this, but I don't want to start my pinning in this area. I would rather be distal to it. You can see here, this is about a 5 centimeter mark. That's where the nerve is going to be, and I want to be distal to it when I start my pinning. You can use 2 pins like has been used here. I prefer to use 2 millimeters or 2.5 millimeter by K wires, and they are terminally threaded, so there is no risk of migration. You should have the position inferior. That means that this pin has to be near the neck of the humerus to give some more stability, and then you need to have a spread of the pins at the fracture site. You want to make sure it's not intra-articular, just like you're doing the skiffy screw. And I prefer to bury them underneath the skin and then come back and remove them. You can leave them out. The issue is that there is a lot of muscle in this area, a lot of bulky, soft tissues. So it always becomes a little bit, it starts draining a bit. There might be pin track infection issues. Remove it at 4 to 6 weeks once we see initial callus. You can add a 3rd pin from the anterior aspect. So these are from the lateral aspect. You can add 1 more pin from the anterior aspect, and you can add a 4th pin from the top, depending on how much combination of what you're trying to fix. So these are the typical configurations that is used for pinning proximal humerus fractures. Again, the starting point is about 2 times the distance of the axillary nerve. So 5 centimeters from the acromion, starting point usually about 10 centimeters from the acromion. If you're going to leave the pin out, make sure that you bend the pins or you put a ball or something to prevent the pin from migrating. Pins have migrated in really a short time. It doesn't take a loss to follow a patient to present with pin migration. It can happen while the fracture is healing. And there are reports of pin migration into the spinal canal, into the chest. There has been a death reported in a 5-year-old kid because of penetration of a pin into the aorta. So whenever you're using pins in this area, in the shoulder area, few things. One is that use terminally threaded pins or threaded pins so that it doesn't migrate. The second thing is, if you're going to keep them out of the skin, then bend the pins so that they don't go into the skin. And the third thing is to be careful. That means just see them back in follow-up and take an X-ray to make sure that the pin is staying in position. The other way to avoid it is to use screws. Lately, we have been using screws as well to treat these injuries. So once you get your pins in, then it's just a matter of putting a cannulated screw on top. You can also use elastic nailing, especially for pathologic fractures where we want to put the nail in to prevent the entire bone, or for longer duration. Elastic nailing does help quite a bit. You can put 1 or 2 nails, and the nails can also help in achieving reduction, just like the Metazor technique for your radial head fractures, or radial neck fractures. You can use these techniques for reduction as well, as shown here. If the fracture is irreducible, there is frequently some interposition. Biceps tendon could be interposed, or it could be the muscle or periosteum interposed. One thing you can do is intrafocal. This is one of my patients. Just like you use intrafocal in other areas, you can use a blunt instrument to do manipulation around the fracture site, get it to reduce, and then pin it. Or if you can't get it reduced this way, then you can make a small incision to put your finger in through the deltopectoral groove. You don't have to make a big approach. You can just make a small incision here, put your finger through the deltopectoral interval into the fracture site, and just clean the fracture area, and you'll be able to reduce it. So it doesn't take a big approach like a typical deltopectoral approach to reduce these fractures. You can get pin track infection. This is one of my patients who had infection after pinning. So that's why I usually don't like to leave the pins out. I bury them. There could be malunion. This is, again, one of my patients who had a malunion. I treated him conservative. I'd offered him surgery, but the family chose to have non-surgical treatment. If you have to resolve this, this would be an osteotomy for humerus varus. The patient was okay, even with limited abduction. Like you can see here, the patient said, "I don't have pain. I can do everything I want to do." He was not an athlete, and so he did not have treatment. But you can get a malunion. So this patient was 14 years of age, and so 11 years is a cutoff. So if you have significant angulation, which means more than 45 degrees angulation, or if it's translated significantly, then you need to, like the grade 3 and 4 of Neer-Horowitz classification, you need to fix these fractures, at least reduce them. And you can get limb length discrepancy if you have a growth arrest, though that's not an issue, but I've seen patients with one side being shorter than the other side. If you look from behind, you can see it well, and the patients typically don't complain of issues with that. Here's a fracture from the entry site. So you want to make sure that when you're entering, you don't make too many holes. This is too far distal. I would not go so distal. I would probably, just be around this area here. Other thing is that, if you have these fractures, even if they heal, they may have limited remodeling. So some patients, limited remodeling is typical in patients who have some nerve issues, some muscle issues, some brachial plexus injury, for example, or if they have, so this patient had a syndrome where the patient had proximal muscle weakness. If you don't have muscle forces, normal muscle forces, you would have limited remodeling. And this patient had significant symptomatic malunion of the humerus and underwent an osteotomy. So all fractures are not benign, and you have to be careful. An individual approach to a patient is what is needed. We'll just talk a little bit about the shaft fractures. That in neonates, it's birth trauma. And if they're less than 3 years of age, you need to consider non-accidental trauma. If the patient is between the ages of 3 and 12, there could be a bone cyst or a benign bone tumor. And then once they're nearing skeletal maturity, you treat them like adults. So for both fractures, simple immobilization is what you need. And if you have a pathologic fracture, then you can still treat it conservative if it's not displaced. If it's refracture, or if you want to treat it with a nail, then that's another option. Otherwise, mid-shaft fractures, you can treat them closed. We treat them with a coaptation splint initially and then transition to a functional brace as seen here. And depending on the level of the fracture, you can also use a hanging arm cast. Here is a segmental fracture treated with a hanging arm cast. And the malunion, even though there may be some malunion, it usually doesn't cause any functional loss. Varus is not tolerated very well. It's typically an issue in obese patients who have to keep their arm a little bit abducted because of the size of their chest, and they fall into varus. So obese patients might benefit from a little bit careful observation if needed, surgical treatment. But these fractures typically remodel well. The shortening is not an issue. It can be compensated for overgrowth, and non-union is uncommon, as well as palsy is uncommon in kids. And that may be to do with the thicker periosteum, which may be preventing the radial nerve from getting in touch with the fracture. So we don't see too many issues with radial nerve palsy, especially in skeletally immature patients. All right, so we had an hour of talk, and so we can have questions now.
Yeah, Sheetal, beautiful. This is absolutely an epic talk on fractures around shoulder. And if there are any questions from the audience, you can unmute and ask or put it on the chat box.
Sir, Sheetal sir, I have a question. This is Santosh.
Yes.
Yes. It's regarding that intrathoracic displacement you said. So suppose if there is an intrathoracic displacement and obviously we contemplate surgery. So is it the routine approach through which we approach that fracture, like the deltopectoral approach, or is it?
So, intrathoracic displacement is very rare. There are only a few case reports. You might not see it, but yes, if you do have it, two things I would recommend. One is a deltopectoral, maybe a little bit extended approach to make sure that we can see everything in the normal. Before you approach the fracture, you want to see what the normal structures are. So it's better to use an extended approach and to have a general/vascular surgeon with you. So, whenever we're dealing with instances where you may encounter, bleeding or thoracic structures, you need to keep, a thoracic surgeon with you. So we are fortunate that we always have, even if we don't book the patient, like book the case with a surgeon, our cardiac ORs are just opposite the orthopedic OR. So we always have someone there. And the issue is, the same issue is with the SC joint injuries, especially the posterior injuries, that, we are not, capable enough of taking care of any other injuries besides the bone and the joint. So you can get, a lung injury, you can puncture a lung, you can get, vascular injury. So you always need to be careful and have help, available, and better to be prepared before than, ending up in a mess afterwards.
Sure. Sir, and also I have a question on the displacement. So suppose if it's close to this adolescence, maybe borderline age 8 to 12. So better to follow the NIRS classification, Neer-Horowitz, for considering the reduction, or can we wait?
Yeah, more than 11 years of age, I would be more concerned about remodeling. So we are talking about, one is the bayonet is not going to remodel. So less than that, a bayonet is acceptable. But after 11 years of age, I would, bayonet is not acceptable. The second thing is an angulation. So more than 45 degrees of angulation is not acceptable after 11 years of age. So you can check the angulation, you can draw a line perpendicular to the Physis and, parallel to the shaft, and you can note the angulation. And if it's more than 45 degrees, it needs to be reduced. A lot of times on an AP view, you may not be able to appreciate the amount of displacement. So always get an axillary view, because axillary view is going to show you the maximum angulation and displacement. So don't trust your AP and a scapular view or anything short of an axillary view.
Thank you, sir.
Yeah, any other questions from others? Sheetal, for clavicle fracture, what is your implant of choice? In younger patient, like you at that 7 or 8 year old, where there is an indication to operate. Have you tried elastic nails, or it would be plate even for that age group? And do you use specialized clavicle plates, or just routine plates you bend and you? What do you?
Yeah, so in the literature, the plates versus nails have not shown significant difference. So it would be your choice. I've not used a nail for a clavicle fracture. I've always plated them. When it comes to medial third and lateral third, there is a huge role of using anatomically contoured plates or specialized plates because they have cluster of holes. Your fragment is very small. It's better to then have an anatomic plate so you can put three screws at least in a small fragment. In the mid-shaft clavicle fractures, you can use a regular plate, but it would require a lot of contouring. So we by default use clavicle plates. That means anatomic plates. And those plates are distal plates. They have anterior plates and superior plates. It all comes in one set. And at least one plate would fit really well. And sometimes it's not the plate that you want, like in the sense that you're putting the plate superiorly, but it may be the anterior plate that fits perfectly on the superior side. And we prefer to, use anatomic plates, but if you don't have those, or if they're expensive, you can use regular plates. It's just that you'll have to contour them quite a bit.
Yeah, so it's not just bending; it's also twisting. And
yes, bending and twisting. Yes.
And bending.
Sheetal, there was a POSSI webinar 2 weeks back, and they showed some specialized pin for clavicle. Do you have any idea for that? So,
No,
we don't have.
No, I have no experience with those. I've read the reports of those pins as well as the nails. I think they are more popular in Europe, but here, and all the colleagues that I have spoken with, I don't think anyone is using nails here. But I think the literature, comparative literature shows that nails work really well as well, just like plates. And there may be some advantages of a smaller incision and less issues with nerve, the numbness part of it. And there may be some advantages, but I don't have any experience with nails.
How often do you come across congenital pseudoarthrosis of clavicle?
I would say once every couple of years, I'll see an adolescent patient with congenital. I've only operated on 2 patients. Rest I've treated conservative. I'll just send them to rehab. I showed one of the cases which failed, and the other one did heal, but I would not recommend fixing it, though. I don't know what your experience has been. Have you fixed?
So I have same 2 cases. Both were pretty young, and I had used a simple K-wire. Both did well. So didn't use a tricortical graft, just used loose graft, really.
Okay.
So I think I have had then another 2 patients which were pretty grown up and they didn't have much issues. So I think they were lost to follow up after that. So I've seen about 4
so,
of them.
at least the textbook answer is to just try to avoid surgery. If someone is asking my opinion, I would just say, especially in younger patients, the issue comes up when they are 14, 15 years of age, is when they start noticing some prominence and they may have some cosmetic issues, but functionally they have not had, at least in the literature, it has not shown to have significant issues. Because we have seen patients with cleidocranial dysplasia who have absent clavicles, and they are okay. I mean, as far as their function is concerned. So we know that it's important as a strut, but if you don't have it from birth, probably there are a lot of compensation around the upper extremity.
So just to add to this, I think it may be a very good idea for all those kids who are having a right side clavicular fracture is to document a decent union, because you might miss congenital pseudoarthrosis of clavicle and people may blame you. So for postgraduates, it may be a good idea to follow up right-sided clavicle more closely than the left ones, unless it is a dextrocardia.
Correct. Would agree. So what about clavicle fractures in adolescent? What is the age cutoff for surgical treatment for routine fractures? Like, are we treating all of them with close treatment, or at what age do you operate?
So Sheetal, I have only one patient, a doctor's colleague, this is a daughter. She was about 14 when she fell, and after a week's time she showed shortening. So I had spoken to them regarding scar and possibility of surgery. They said that if we can try conservatively, we can do something. So I took her under GA, and I reduced it and apply a very tight figure of 8 bandage. And ultimately she did well. Now she's about 5 years down the line and she's a second MBBS student. So that is the only clavicle I have done some intervention, but I've never treated a clavicle fracture operative. I don't know about Taral. I have never
So
treated.
Sheetal, we don't seem to be having so much of shoulder injuries. So we do see, with increasing spots, more lower limb trauma and more complicated lower limb trauma. Occasionally, even pelvic-scapular injuries in children, but the type of glenoid fractures and other fractures which you showed. So I'm attached to 2 hospitals which do take care of pediatric trauma, but not many. In fact, not much. But I'm sure that it would come with time. I just want to ask the audience what is their experience about apart from upper shoulder, upper humerus fractures and clavicle fractures. About other fractures around the shoulder which Sheetal showed. How frequently do you see, or have you had any experience of managing? If anyone wants.
So apart from those two, we never actually had, sir. 8 years down the line, I'm practicing, I never had. Only one lateral and clavicle fracture, that too in a 3-year-old. Recently, just 3 days back, I had a referral for that. So I just put a cuff and collar. He has a head injury as well. That's the only clavicle fracture I had experience in children.
Scapular fracture we have treated just 2 so far last 5 to 8 years. That's what I remember. And that was with an adult colleague. That is our adolescent fractures. Some of them may be going to our adult colleague also.
Yeah, sir. Most commonly seen as the clavicle fracture only. Apart from that, other injuries we don't commonly see.
So Sheetal, how often have you come across benign hypertrophy of medial end of clavicle? Because that mimics very much like fracture, sometimes inflammatory conditions, and I've had some patients who were put on antituberculous treatment just because of the bone enlargement. Have you come across such entity?
No, I have not seen any hypertrophy, but there are certain things that we see in clavicle that are, I've seen some benign tumors of the clavicle and I've treated them, like Langerhans cell histiocytosis, LCH. We see a lot of lysis of the clavicle in weightlifters, and that might need treatment. Sometimes distal clavicle resection, and we have done those in wrestlers. But I've not seen an hypertrophy. I don't know if it's from infection or previous injury or something, but not on the medial side. On the lateral side, we see it because you can get a lot of stress in the AC joint. Tennis players, overhead athletes, you see changes in the AC joint. So you can have osteophytes, you can see that it's hypertrophic, you can get lysis of the clavicle, but I haven't seen it on the medial side.
So Dr. K.M. Shah had published long back a medial end of clavicle hypertrophy in children, adolescents. So I have inherited one of his cases, and then I have had 1 or 2 of my own. So that's an interesting phenomenon. So one more funny thing, I had one clavicular non-union in which I had operated a sprangial shoulder.